Okay. Let's say this is a 65-year-old comes in presenting with or complaining of vaginal itching, um, mainly at night. Um, or would you how would you evaluate this patient?
For this patient, I would go through her history and then physical. In history, I would want to know when it began, if she's ever had anything like this before. Again, she reiterating that it's worse at night. If she had any new sexual partners, any change in discharge or odor. On physical exam, I would be looking for change in tissue color, odor, discharge, um, and that's what I would do.
Okay. Um, what is your differential at this point?
For a 65-year-old with vaginal pruritus, my differential includes atrophic vaginitis, infections such as yeast or BV. Could also be something like pinworms, and on my differential is vulvar cancer.
Anything else?
She could also be having skin irritation from urine incontinence if that is something that she had endorsed. She could also have chronic simplex chronicus, lichen sclerosis, um, which are other reasons for pruritus.
Okay. So, you ended up doing an exam on her, and uh, at this time you are suspicious for lichen sclerosis. What would be your evaluation and treatment at this time?
In my office, we need prior authorization before being able to do a vulvar biopsy. So I would prescribe to her clobetasol and vaginal estrogen to apply the clobetasol twice daily for 4 weeks and then daily for 2 weeks, and then instruct to do every other day with the goal of being to the lowest effective dose. And the vaginal estrogen, I would recommend nightly for 2 weeks and then twice weekly thereafter. But I would also schedule her for a vaginal biopsy to confirm the diagnosis.
Okay. I would scratch the part where you talk about authorization. So
Oh,
during the test, everything is like the ideal environment, right? So you either do the biopsy, then treat, or you treat, and if it's not getting better, you do biopsy. The like
oh,
insurance has nothing to do with how you manage the patient. Okay,
okay.
so it's like, and because these are structured cases, right? So you basically have like you can do whatever you want. Like there's no
It's
constraints, right?
okay.
So
Okay.
you do what's best for the patient. So if you think you want to do the biopsy first, you do the biopsy first, or not. So
Okay.
it's completely just what you want to do, not like, oh, if the insurance covers it, I would do this. If not, then you understand what I'm saying?
Yeah.
Yeah. So
Um,
would you do a biopsy
you
first, or would you treat her first?
For my patients, I would treat first and schedule for a biopsy with effective treatment, feeling more reassured that it could be lichen sclerosis, but I would want the histopathologic confirmation. If there was no improvement, um, I would investigate the other causes.
Okay. So I still don't know if you're gonna treat her first or do a biopsy first.
I would treat her first.
Okay. So that's completely legit, right? So you can treat her for 4 3 to 4 weeks, and then if she's getting better, you don't need to do a biopsy because you pretty much confirmed it. But if
Do
it's
you
not
think
getting
you
better,
do you think you
or
would Do you think they'll mark me off? Because I would do a biopsy on everyone. Because if it
Okay,
is lichen
then you say
sclerosis,
that.
okay,
Cause I would do a biopsy first, then treat her, like at the same time, you know, because like right now there's no insurance problem, right? So I would do a biopsy at the same time as me starting the treatment,
initiating treatment.
right?
Okay,
Because
yeah,
it's just clobetasol. It doesn't hurt anything,
right.
right? So you can always start treatment, but I would I would say like I want to do a biopsy just to confirm my suspicion. But I think the example people did say that you can treat her, and then if it's not getting better, then you can do a biopsy to make sure it's not something else. Because most likely it is probably lichen sclerosis or chronicus, whatever it is.
Yeah,
Treatment's the same, right?
yeah. That's
But
and I mean for
yeah,
me the benefit of doing
but for me, I would say I would always do a biopsy.
because that's I always do a biopsy, but I usually do start treatment. But yeah, again, it's because of the insurance stuff. I can't usually do a biopsy the same day. But even if we could, yeah, I guess if I could, I would probably do a biopsy the same day.
Yeah, I mean, like if you can do a biopsy right away, why would you want to wait?
Wait,
Because
yeah,
you're saying you want to do a biopsy anyways, right?
yeah. So
So
I have a patient on my office list who, because it's, the real world, not the ideal world, I did have to wait to do the biopsy.
okay,
I so I could explain in my office, though ideally I would like to do them at the same visit. We have to get prior authorization.
right, but
So in the
that's your
meantime,
case list, right?
initiate.
That's different.
Okay. So
This is
yeah,
like in
I
the
just want to
ideal
make sure.
world, this is like the structured cases. So like, what's the
Okay.
best option for
Yeah,
this patient, or what would you do in an ideal world? So you would just I would just say
we
that.
do the biopsy. Okay,
Yeah.
cool.
Um. Okay. So let's see. Let's do something else. Okay. So instead of this patient, instead of lichen sclerosis, this patient has you did a biopsy and it comes back. It's um no, she doesn't. Oh, this is a completely different patient or scenario. So
Okay,
this patient has condyloma accumulata.
okay.
Um, what are your options for this patient? What are your treatment options for this patient?
Options for this patient include freezing the warts, TCA, or podophyllin. I believe there's also laser treatment, though I do not have experience with this.
Okay. What would you do for this patient?
In our office, we do the TCA topical treatment.
And how would you how would you apply the treatment?
For these patients, I use Vaseline to surround the lesion to protect the skin. I then apply the TCA directly to the lesion.
Okay. And then patient goes home. That's it.
Counsel patients on hygiene and that it may require several treatments, and I have them follow up in 2 weeks to monitor response.
Okay. Um. So for TCA, I think it's supposed to be weekly application for at least 4 weeks. Um,
So also, here's an interesting thing. TCA got pulled by the FDA.
right. It's still on. You can still buy it over the counter.
Yeah, it's just I don't know
I
if they're gonna
would that for that reason I use a microbot. Um, so it's and also for TCA you have to have the patient come in You have to apply it. Versus Americamod, they can apply it themselves.
How
And
do,
then
do they do that?
it's a cream, right? There's a two different
Oh,
solution
that's what
percent
I'll dare it.
solution. I usually use the 3.75% solution. It's called like Clara,
Yeah.
and then you just have them put it where the lesion is, and then at night, and then in the morning you have them shower or like wash that area, because if you don't do that, it's gonna cause a lot of irritation. And then you tell them it's gonna take at least 4 weeks, up to 8 weeks, to see an effect.
Okay. Okay.
Yeah. There's a really good. I don't. I think you have up to date, right?
That's I'm reading it right now.
Yeah. So there's a really good article about that.
Nice.
And then there's also surgical options. Cryoablation versus laser versus just Bovi electrocautery.
Okay.
Okay. All right. Let's talk about something else. Okay. Let's wait. I feel like we already done syphilis, right? Um.
We could do it again. I mean, that was a long time ago.
Okay. So, what are the stages of syphilis?
There is first stage, latent, second phase, and then third stage or late stage.
Wait, say that again.
There is first stage,
Uh huh.
second stage,
Uh huh.
and then latent stage, and then late stage.
Okay. And what are the symptoms of each stage?
Stage, you can see ulcerative that are painless at the vulva. You may also see a rash of the palms and soles. The stage, you would see the lesions on the palms of hand, soles of the feet. And then in latent stage, there are no symptoms. In the late stage, you can start having neurologic symptoms and an Argyll Robertson pupil.
Okay. And the what is the treatment? What's the preferred treatment for syphilis?
Or if you can confirm that it is a new infection, it is one dose of Pen G. Is if you are unable to determine what stage, it is late in our third stage, then it is 3 doses of Pen G weekly for 3 weeks.
Okay. And what is how do you test for syphilis for your practice?
Our practice uses non-treponemal and then confirmatory with treponemal testing. So we do RPR with confirmation by FTA ABS.
Okay. Is there any what are some possible causes of false positive RPR?
False positive RPR can present or can exist with positive pregnancy tests, history of lupus, history of mono infection, um, and those are the confounding variables that I can think of at this time.
Okay. Um, so let's say this patient had syphilis and then you treated her. How would you monitor this patient afterwards?
patients, what we'd like to see is a fourfold decrease in RPR titer levels. So we would monitor the RPR first at 6 months and then at 12. If she were pregnant, would repeat the test in 3 months to ensure it is not increasing, but we would not expect to see full treatment response with that quickly.
Okay. So you said 3 months you would retest her, or
In pregnancy, yes.
okay. Uh,
Otherwise, we would do 6 months and 12 months.
okay. And then how would you know the treatment is working?
If you see a fourfold decrease in the RPR titers.
Okay. And then when you say fourfold decrease, can you give me like an example?
So if the titers went from 116 to 1.8 to 1.4 to 1.2, that would be a fourfold decrease.
Okay. Um, okay. Pretty good. Let's say this while you're treating this patient, would you how would you treat this patient in terms of would you treat them outpatient or inpatient? What if the patient is pregnant?
Patient is pregnant, I would treat them outpatient after I've confirmed they do not have a penicillin allergy.
Okay. Let's say this patient start having a rash after the first dose of penicillin with you know tachycardia and headaches. Um, how would you
My
manage
cons-
this patient at this time?
my differential would include Jerish Hersheimer or possibly allergic reaction. I would admit her for monitoring of vital signs and fetal monitoring with EFM and TOCO. However, I would not, and I could give IV fluids, but I would just monitor to ensure that the patient was not having a worsening status and not going into preterm labor.
Okay. So you wouldn't treat this patient with anything?
If she were febrile, I would give her Oframev. I would give IV fluids. If I were concerned for an allergic reaction, I would consider IV Benadryl or albuterol. But I would not tocalize this patient.
Okay. All right. Pretty good. Um, so just one thing about the stages. So there's I think you said first stage, second stage, and latent phase, right?
Yep.
Or something like
Late
that.
and then third. Yeah.
Okay.
Oh, has early
So
and
yeah, so to my understanding, the latent phase is part of so it's called primary syphilis, secondary syphilis, and tertiary syphilis, right? So those are the stages,
yeah.
and the latent phase is part of the secondary syphilis. And then in the latent phase, there is a early latent and then a late latent. But you can double check on that.
I think that
But
you're right. I never think of the stages. I'm awful at remembering the stages for syphilis. Because we only ever see them in latent.
right, exactly. Um, but like I said, this exam is just out of just questions can come out of nowhere. It's very
Yeah.
annoying. So it's never bad to kind of know some details. But also, if you don't know details, I don't think it's that big a deal because it is graded on a curve. So like, if it's a hard question for you, it's a hard question for everybody. So um,
Yeah.
but yeah. Yeah. So the second stage is where you get the palms and soles, the rashes on the palms and soles, um, and then you have the condyloma lata lesions as well.
Yeah.
So the primary stage is the chancre, right? The painless ulcer,
Yeah.
and then you get the condyloma lata in the second stage, and then it goes into a latent phase, but that's still secondary syphilis. And
Hmm.
then you have the tertiary syphilis where you get the gummas, neurosyphilis, cardiovascular syphilis, and all that good stuff.
Yeah.
Okay. Um, what else?
I
Uh,
get the treatment right. I
treatment,
can't remember
yes.
the dosing.
I think it's like 5 million, but
It's 2.4.
yeah, 2.5
Okay.
million, whatever. I don't know about it. I don't think you need to know the dosing because that's not what we don't deal with that a lot. So you can always just say I will look it up the dosing just to make sure. I don't think they will even ask, but if they do, you just say like, I think it's this, but I will confirm it by looking it up before I give it to the patient or something like that.
Yeah.
Um,
Um,
okay. So let's see. Let's say this patient comes in. She's 39 and she hasn't had a
Wait,
period.
hold on.
Hmm?
In pregnancy for Jerish Hirschheimer's, I don't have to do anything, right? It's just supportive.
Yeah, it is supportive.
Okay.
Um, so she's 39. She hasn't had a period for over a year. How would you evaluate this patient?
This patient, I would do a history and physical. I would ask her a detailed history about any medical issues, medications she's on, if her cycles had been regular up until that point, if there was any recent weight gain, weight loss, unexpected hair loss, dry skin. I would ask the patient if she had any new onset facial hair. I would ask the patient family history if when her mom went into menopause or her sisters. I would ask the patient if she was having any hot flashes or other vasomotor symptoms. On physical examination, I would be examining the skin for signs of hirsutism or acanthosis nigricans and doing a pelvic exam to assess for adnexal masses, uterine abnormalities, or any changes in vaginal atrophy.
Okay. And then in terms of lab work or testing, um, what would you
For this patient,
obtain?
I would do an in-office urine pregnancy test, and then I would do blood work assessing again beta HCG in case she was below the discriminatory value on a urine test. I would order a TSH, FSH, estradiol, um, and potentially an AMH based on her history.
AMH?
If she reported that she had a family history of premature ovarian failure, order an ultrasound.
Okay. Um, okay. So what is how would you diagnose someone for primary ovarian failure?
If this was a patient who had lab work suggestive of ovarian failure with an FSH over 70, an AMH under 1, um, and family history of premature ovarian failure with no personal history of radiation, I would also order a karyotype to assess for Fragile X or Turner syndrome. And that would be my diagnosis.
Okay. Does AMH of less than 1 make you primary ovarian failure?
Necessarily, but it can help fill the picture.
Okay. Um, so how would you counsel this patient?
first try to determine if this patient had goals for um, future pregnancies. If the patient did not have goals for future pregnancy, I would recommend, in terms of her own personal health, that we should consider hormone replacement as she going into menopause at a young age increases all-cause mortality.
Any
Also
any other?
recommend that the patient take calcium and vitamin D. Recommend that she does weight-bearing exercises, and that she would want to focus on her cardiac and bone health.
Okay. And how would you what kind of hormone replacement therapy would you give this patient?
My preference for hormone therapy is a transdermal estrogen with micronized progesterone.
Okay. And what are some of the typical doses you give patients?
I usually will do transdermal Clamera. It's a 0.325 milligram patch, and I do micronized progesterone 100 to 200 milligrams.
Okay. And what do you tell the patient in terms of side effects or adverse
I
effects?
I counsel the patient that there is a risk for DVT, hypertension, though I'm not as concerned about, I'm just not going to say that, that there's a risk for DVT, colon cancer, possible risk for breast cancer, and possible risk for uterine cancer if she were to stop the progesterone.
I think it decreases colon cancer,
Yeah,
right?
it does. Yeah.
Um, okay. Let's see. Uh, let's say this patient is 66 years old and she's been on um, hormone replacement therapy for vasomotor symptoms for the past 10 years. And now she's coming in and she was told that being on hormone replacement therapy at her age is not good. And she just want to see if she should stop it or is she okay continuing.
There is, to my understanding, currently no strict endpoint for when a patient needs to stop hormone replacement therapy. Or I do counsel them on the importance of annual mammography and using the lowest effective dose.
Okay, so um, you would try to titrate her down.
To the lowest effective dose.
Okay. Uh, let's see. Let's say this patient is a 14 years old. She comes into the ER because she's having heavy menstrual bleeding. Um, and you were called by the ER doctor because her vitals are slightly unstable. Um, so how would you begin to evaluate this patient?
This is a 14-year-old, you said?
Correct.
So I would go to patient bedside, evaluate vitals, perform history, asking if this is a change in her cycles for her, if she's ever had any bleeding issues in the past, such as during dental work, or if her nosebleeds are heavy nosebleeds. I would ask when her menses started and ask her to characterize them. Um, I would um, ask her parents to step out of the room so that I could ask her if there was a chance that she was pregnant. Um, and then I would ask for chaperone so that I could perform a physical exam to assess for any lacerations, anything physical that could be causing the bleeding besides menses, any adnexal masses or uterine abnormalities.
Okay. Let's say while you're doing your evaluation, her vitals, her blood pressure is 89 over 45, and her heart rate is 120. Um, what would
I
you
would
do?
ask for I would ask for two IV large bore IVs. I would ask for a 1 liter fluid bolus and ask for a cross match of two units packed red blood cells. Um, but I would also ask her parents what her baseline blood pressure is. As in the pediatric population, it can be lower at baseline.
Okay. And let's say her blood pressure continues to drop, and her heart rate is now 150, and patient starts to lose consciousness.
I would bring this patient to the operating room. First, I would make sure that we have fluid resuscitation, blood component therapy ongoing. I would notify anesthesia. I would bring this patient to the operating room to perform a DNC, and I would initiate IV estrogen to decrease the bleeding. I would also administer tranexamic acid and ensure that she has SCDs in place.
Okay. And let's say patients in the OR, you've started to perform your DNC. Patient continues to have um, pretty brisk bleeding through the uterus. What would you do? Hello?
This patient, in a patient who has a negative beta HCG and no possibility that this is a retained products or miscarriage, um, I would continue to administer red blood cells or blood component therapy because I would not want to perform a hysterectomy. I would contact interventional radiology for the possibility of an IR embolization as it has not been evaluated for future pregnancies. I would want to be very conservative in my management of permanent surgical options.
Okay, so the patient is active hemorrhaging and her vitals are unstable. You're gonna contact radiology for a
Or have
embolization.
them on standby as I need to give them an hour heads up. So I would have them on standby in the hopes that this would decrease. Um, and I would also call for help from our gynecologic oncologists.
Okay.
If this patient had reported a positive history of a bleeding disorder, I would also consider administering desmopressin.
Okay. Let's say she has no history of bleeding disorder or a history of any bleeding prior to this. You're in the OR. You did DNC. Um, you did a couple passes. Patient's still briskly bleeding. Well, is there any other intervention you could try?
I would attempt perhaps a Bakri balloon. However, most of the data for which I'm familiar is during uterine atony after a delivery. I would want to attempt everything prior to definitive management.
Okay. Yeah, you can actually, yeah, you can try a Bakary balloon actually if they're hemorrhaging. You can just basically,
Oh.
tamponading
Yeah.
the and the endometrial lining. Um, okay. So let's say her bleeding is getting better. Um, you were able to stop the acute bleeding. Um, what medication would you start her on?
I would first continue her on 24 hours of IV estrogen to ensure that her bleeding is under control. I would then transition her to oral contraceptive pills with estrogen and progesterone.
Okay. Um, We didn't talk about, let's talk about transfusions. What are some of the transfusion reactions? What are some of the life-threatening transfusion reactions?
Uh, Life-threatening transfusion reactions include anaphylactic reaction to incorrect type and cross-matched blood products. They could have taco or trolley um, as the three primary life-threatening transfusion reactions.
Okay. Um, what if the patient has a fever, but while you transfusion her, but there's no other symptoms? Would you stop the medication, or would you stop the transfusion, or what would you do in that sense, in that case?
If a patient had stable vital signs but was indicating a low-grade fever, I would slow down the transfusion, administer Ofirmev and anhydramine, but I would
Ofermet,
not
wait,
stop the treatment.
Ofermet is IV Tylenol, right?
Yeah.
Okay. Okay. You actually, I think you're supposed to stop the transfusion because febrile non-hemolytic transfusion reaction is they're reacting to like antibodies in the blood. So you're actually supposed to stop it, and then you're actually supposed to let the bank know that there's some there's some antibody in this blood that's reacting to the patient, and they're not supposed to use it anymore. The one that you're thinking of is a allergic transfusion reaction where they get hives and itching. That one you don't have to stop the transfusion. You can continue to give the transfusion. Just give them some Benadryl, because that one you can continue. But if they have fever, that means they have the febrile non-hemolytic transfusion reaction. That one you're supposed to stop. Just FYI.
Hold,
Uh,
um, hold on, I'm double checking that. Donor leukocytes,
right.
accumulation of cytokines, diagnosed, exclude everything else. Oh yeah, stop. Okay.
Yeah.
Huh. All right, cool. Thank you.
Let's see what else. Um, what do you use to um, evaluate a patient for their DVT risk for after or prior to or after surgery?
Prior to surgery for each of my patients, I use the Caprini score and I assess their personal history of medical issues as well as the class of the surgery.
Okay. Um, so with Caprini score, is there what's the score that you would let's say start patient on anaphylaxis? Not anaphylaxis.
Anticoagulation.
Anticoagulation.
I would need to double check that. I generally use the calculator.
Okay. Um, let's say this patient is pregnant and she was on a prophylactic dose of anticoagulation. Uh, what do you usually use?
During surgery or during labor or during when?
Just during let's say she has antiphospholipid syndrome.
And we use low molecular weight heparin.
Okay. What dose do you use?
A patient with APLS and no personal history of DVT, we would use prophylactic, so low Nox 40 milligrams.
Okay. And then, do you, as the patient approaches labor or the due date, do you do anything different, or you just keep them on it until they deliver?
My practice, we do not transition to heparin. So what we have them continue their low molecular weight injections, the Lovenox injections, and we schedule their inductions between 39 and 40 weeks. Or if it is a repeat C-section, we have them do their last dose 24 hours prior to surgery.
What if the patient comes in before your induction time and she's in labor?
We do counsel our patients that it may be possible that they cannot get an epidural and that they may require C-section under general anesthesia.
And how many hours do you wait before you can give a patient epidural?
Prophylactic
Uh,
heparin dosing, Lovenox dosing, we would wait 12 hours.
and then postpartum, when do you restart them on anything?
Yes, so postpartum for vaginal delivery, we would restart Lovenox in 6 to 12 hours. After a C-section, 12 to 24 hours.
12 to 24 hours. Okay. Let's see. All right, last topic. Let's say this patient comes in, this is the office case. Let's say this patient comes in with complaining of discharge in one of her nipples. And
Okay.
she's 35. How would you evaluate this patient?
Evaluate this patient with history, physical, and lab studies. I would ask this patient when this started, if she's had a recent pregnancy, either pregnancy loss or delivery. I would ask her if she's ever had this before. I would ask the patient to characterize her cycles. I would ask her if this leaking has a color or is it constant? Is it only when expressed? I would then perform a physical and see if I could express the fluid. Um, I would, if available, want to perform an FOBT to determine if there were any red blood cells. If the fluid were clear, then I would, and a patient was having irregular cycles, I would order a prolactin and thyroid. And likely for a 35-year-old, I would also order a mammogram if this had been an ongoing problem.
Okay. Um, let's say the the prolactin is 50. What would you do?
I would ask the patient if she had started any new medications that could increase prolactin levels, such as antipsychotics, antidepressants, Reglan, any of these medications. I would then ask her to repeat the lab work.
Fasting, right?
Fasting, yes,
Okay.
levels for prolactin.
Yeah. Okay. So let's say it's still high after you repeated it. What would you do?
If the level were 50 and her thyroid was normal, I would likely consult endocrinology. I would have on my differential a prolactinoma, but generally those are seen with higher prolactin levels. I would ask the patient about headaches, changes in visual fields, um, and again, her cycles.
Okay. So you
Also consider a 3-month trial of OCPs and repeating the.
okay. Um So you will not do any imaging at this time.
Not at this time.
Okay. So let's say she comes back after 3 months, trial of OCP continues to have mildly elevated prolactin. Um, what would you do?
At this time, I would order a head CT and refer to endo.
CT?
CT.
Okay. I think I asked you this question before.
Yeah, and I think it's MRI,
Yes.
right? It is MRI.
Yeah.
Yeah.
Um, let's say she does have a micro prolactinoma. Um, what would you do?
These are not lesions that I treat, but I'm aware that the treatment involves carbergoline or bromocriptine. And I would counsel her that if it were over 1 centimeter, that they would consider surgery.
Okay. Yeah. I mean, you could just say I would say I would say I just start them on cabergoline and then refer them to um, endocrine. But I don't think you need to. But yeah. Okay. So yeah, it's MRI. I think like last time you said CT too.
Yeah, I know. I don't know why my brain loves CT.
I
It's
mean,
MRI.
CT is the go-to for most
For
things.
the head. I know. Rude. Um,
All right.
what,
Any other questions or anything?
for the 14-year-old bleeding, is the only thing that I was like missing off the IV estrogen, but jumping to a Bakri earlier.
Yeah, I think they just want to make sure you try something else other than just a DNC. You know, I think you can still do like you can do Bakary. You can do like Foley balloons. Like just put like
Yeah.
6 of them in there or whatever. Just any type of like tamper knotting device. But you're right. You're not supposed to like jump straight to like hysterectomy because she's so young. Um, but yeah, I think you're fine because you're trying to like conserve her uterus, so that's fine. But yeah, like I had a couple of structured cases like that, just like all of a sudden like the patient is like decompensating, and then it's like it turns into an emergency. Um, I did not like. I think a better way. I didn't do that, but like I think if I had done it again, I would like say like, oh, I would acknowledge that this is like a emergency situation, right? I
Oh,
understand this patient is acutely decompensating. This is becoming a more emergent situation. I would, become. I would be more. I will act more quickly to gather whatever I need to bring the patient to the OR. I didn't say that um, during my exam, but I feel like that would have been more um, make it more smooth. Um, but yeah,
okay. Yeah, that's a good call.
yeah, just like acknowledging that this situation is becoming more urgent or more
Urgent.
acute, so that your examiner knows that you understand.
Aware of it.
Yeah, that you're aware this is not just like a your run-of-the-mill office situation anymore, right?
Yeah.
um but yeah, I mean, I think you're gonna be fine. Just you know you're gonna miss like little things here and there. Just I feel like I missed so many when I was thinking back, but I passed.
Right.
You'll be fine.
That's yeah, fuck.
Yeah.
Hey, for premature ovarian insufficiency, it's just the FSH or can you do an AMH?
I wouldn't do AMH because AMH doesn't give you that much more information. Like if she's trying to get pregnant, that's a different story, you know. But AMH is not a, you don't need it for any type of diagnosing premature ovarian failure. So I
Okay.
wouldn't say that I
Okay.
offer it or I draw it. But
Okay.
what you said, like, you know, since you said it and then I asked you why you got it and what you told me was I feel like that was okay too.
Okay.
But I wouldn't have, done it in the first place.
Okay.
Yeah, because you just need
Uh,
FSH and estrogen, right? Like if
Right.
it if
And
if
then,
if if the
yeah.
estradiol if the FSH is like, mid in the middle ish, like not 70 but like 30 40, then you look at the estradiol to see, to try to figure it out.
Is
Um,
the FSH level over 70?
Over 70, she's definitely um
Menopausal.
menopausal, but sometimes it's like in the middle, like 30 40 ish. And then you look at the estradiol to see, to give you more information. And you can also repeat it in like a few months to see where it is, because it can
Yeah.
fluctuate in the beginning of menopause. Yeah.
Or estradiol if it's under 40, under 35.
Um, I don't want to give you wrong information, but you can look it up on up to date. But I feel like if it was high, it was actually not good.
The
Like,
estrogen's high?
right. If it's high
All right.
and the FSH is like in the middle or something like that, that means like your ovaries are overcompensating. So it's like try to rank up more estrogen to like lower the FSH or something like that. Go look on up to date. Like, I got a little confused about that, um, but I feel like I read something about something like that.
Okay.
Um, yeah. Uh, if you
That's I'm like
want, let me see next week. Next week, if you want, I can do another one with you
yeah,
next week or something like that.
yeah. I'm free the like, evenings of the 20th, 21st, 22nd. I'm on call the 23rd, post call the 24th.
Okay. Cause I'm also on call like Tuesday, Wednesday. I'm also in the clinic. Um, so maybe that weekend we'll see.
What about Monday?
No, I'm working. I don't have any.
Oh, okay.
Yeah, I don't have any vacations. So
All
maybe
right.
like 20 24. It's a
Awesome.
Friday. We'll see.
Yeah.
Yeah,
Just let me know.
yeah. I'll text you.
Awesome.
Okay.
Thank you.
All
I
right.
appreciate it.
Yeah, of course. Anytime. All right.
See you. Have a good day.
Yeah. Talk to you later.
Talk to you later.
Bye.
Bye.